Welcome, everyone. Thank you for joining us for today's webinar, for taking your time out and being here today. So today we are presenting Controversies in Antiretroviral Treatment, presented by Dr. Carl Cohen. Just a little housekeeping before we get started. We'll be running a live questions and answers at the end of the webinar. So if you have any questions, just pop them in the chat box, or even better, unmute yourself after the presentation. And if by any chance you miss on some important points, don't worry, we'll be sending around the on-demand recording when it's available. Without further ado, we will turn the time over to Cal. So Dr. Carl Cohen is an executive director within the Medical Affairs Department of Gilead Sciences. His primary role within medical affairs is serving as the global medical lead for tenofovir alafenamide and the portfolio of regimens based on TAF. Dr. Cohen received his MD degree from the Albert Einstein College of Medicine in New York and his Master of Science degree from the Harvard School of Public Health. And prior to joining Gilead, Dr. Cohen served as the Director of Research for the nonprofit Community Research Initiative of New England. He maintained an internal medicine practice focused on HIV for 30 years within the Harvard system and was a part-time clinical instructor at Harvard Medical School. His research focus was on HIV antiretroviral trials since 1985. Welcome, Dr. Carl. Thank you once again for joining us today. I would kindly ask you to share your presentation, and the floor is yours now.
Thank you, Anya. Hello to all of you. Nice to meet all of you. Thank you for joining me for this hour or so that we have together. I look forward to it. I certainly look forward to sharing the data with you. I really do hope that you will ask your toughest questions. Any question you have, no matter how much you think it's uncomfortable to ask it, would Gilead be upset or anything, please, there's no question that is unwelcome. That's the best part of these for me, is when you have a chance to ask whatever it is that's on your mind. So let's take a look at what I think are some of the big controversies in the field these days. I think you'll agree these are many of them, and then we'll see what you think, as I say, at the end of the program. And please, again, during the program, while I can't see the chat, Anya will be monitoring the chat. Send questions in at any point so we can take care of them at the end. And if there's something, Anya, I need to stop in the middle because something wasn't clear, I can always do that too. So that's me, and you've already heard my background. I've been doing this, of course, a long time, since the 80s, HIV-focused practice, as well as doing clinical trials. And then about 6 years ago, I joined Gilead to focus on medical education, as we are now, starting with the first of the TAF portfolio. So one big controversy in the past few years has been weight gain. And for a couple of reasons, our field has been very interested and curious and worried about weight gain, and for a couple of reasons. And so let me review with you what I think we are learning in the past few years, because I think we have learned a lot about how to look at the data and make sense of the data. So first, let me start with the Gilead data to just kind of as just a place to begin. Hopefully you're familiar that Gilead did 2 studies in treatment-naive persons, 1489 and 1490. These were the studies in treatment-naive persons that got BF-TAF licensed. Gilead, when these studies were being designed, predicted that the future was going to be in the unboosted integrase inhibitor world, and thus bictegravir was developed to challenge dolutegravir, a so-called second-generation integrase inhibitor. We felt that TAF was already superior to TDF, and so you'll see no comparisons in this slide to TDF. It was BF-TAF versus either dolutegravir, abacavir, lamivudine, which was one of the popular single tablet regimens, or BF-TAF versus dolutegravir with F-TAF, because obviously some clinicians didn't want to use abacavir 3-TC anymore due to its longstanding controversy on cardiovascular disease. So simple randomized double-blind trials. Eligibility, hopefully you're familiar with, non-inferiority for BF-TAF versus dolutegravir, abacavir 3-TC has been shown for weeks 48, 96, and 144, all 3 years. As a side point, 0 patients have discontinued on BF-TAP in study 1489 in the randomized trial. It's just one of the more fascinating things for me, because as long as I've been doing this, I don't remember a phase 3 trial with no discontinuations for an adverse event for 3 years in a double-blind trial, but that's where that study is. In any case, all those patients are now in the open label world. Moving from that to the topic at hand, weight change. So this is the weight change curves for the study. And as you can see, people have gained around 4 kilos, a little different between the arms. On the left, the dark line is abacavir. And in this study, abacavir had a clear signal of nausea throughout the study. And there are a couple of studies that show less weight gain on abacavir, and perhaps the nausea is a mechanism for that. In any case, more, however, than not, it's more similar than different. It's around 4 kilos for all 4 arms of the study, if you will. And so if you want to break that down, it's just over 1 kilo per year. And the question is that good? Is that bad? Is that neutral? Is that more than expected? As you can see, there's a distribution. Some people gain more, some gain less. And in fact, if you look at the table, we broke it down in one way, which is that some people gain more than 5% of their baseline weight. So if they weighed 70 kilos, they gain, let's say, 3 kilos. Some gain more than 10% of their body weight. That's around 25 to 30% of people. And some actually don't gain at all. Some actually lose weight or don't change. And that's true for 20 to 25%. They actually lose weight compared to baseline. So what's fascinating already is to say that if you want to say that these regimens cause weight gain, then why do 20 and 25% don't gain? They actually lose weight. So I think we already know that it's not going to be medically sophisticated enough to say these meds cause weight gain, because if 25% lose weight on the same regimen, then we need a different way to describe what we're seeing in our data sets. So one way to get there was this pooled analysis. So Gilead brought forth several academics who were interested in this issue of weight change and collaborated with them. And essentially, we opened up our databases for trials that Gilead had done for the past roughly 15 years and shared with them all of the weight change data. So you may remember some of these studies, they're as far back as efavirenz, and then we go to the first generation integrase elvategravir Kobe, and then rilpivirine studies, and all the way through BF-TAF. So we had a lot of data, as you can see, data from over 5,600 people, a lot of follow-up, and we had weight data, BMI, and we had labs, we had glucose and lipids. So we really want to understand this weight story. One of the first things we learned is, of course, there are many things other than the antivirals people take that influence gaining weight as a treatment-naive person. We've talked for decades that when we start antivirals, there's this return to health. People who are on untreated HIV get sick, and part of the illness is losing weight. And we would see this return to health as a normal part of starting treatment, particularly in people with more advanced disease. And that shows up right in the table. As you can see, people whose CD4 was less than 200 when they started would gain 3 kilos more on average than people with a higher CD4 count. And again, that makes sense. Low CD4 count patients are sicker, they probably have lost some weight, and so this gaining weight is a return to health. People who don't inject drugs are more likely to gain weight, probably because people who inject drugs have impaired access to nutrition or just impaired eating in general, and so they don't gain weight. In this study, people of Black race gain more than non-Black race, although that story is far more complex because Black race is far too simplistic, and people in South Africa gain more weight than people in East and West Africa. So this is, again, a simplification that we'll get back to in another slide or two. And then high viral load. Again, it's the flip side, of course, of CD4. High viral load, you're more likely to gain weight versus people with lower viral loads. So we saw this kind of concept that the sicker you are with HIV, the more likely you are to gain weight. So some of these curves reflect that we're doing good things, and people are supposed to gain weight if they're ill with HIV. So that of course, is hopefully familiar. That's something we learned in the field a long time ago. This study probably is the one that captured the most attention for a couple of reasons. This is a study, hopefully you're familiar, from South Africa. It was presented a couple of times, I think for the first time at the Mexico City International AIDS Conference. Very simple design, 3 arms, treatment-naive persons, starting therapy on either dolutegravir or efavirenz with either FTC-TAF or FTC-TDF. So there's essentially 2 comparisons. If you look at FTC-TDF as in 2 arms, that allows us to look at dolutegravir versus efavirenz. And then if you look at the dolutegravir groups, you can look at TAF versus TDF. On the right gives you some baseline characteristics. You can see it's around 60% women in their 30s or so, 100% or essentially 100% Black race. And then in terms of BMI, you'll notice that the BMI at baseline for the women is 25, which means half the women entering this trial are either overweight or obese already at baseline. And parenthetically, I should note that South Africa has one of the highest obesity rates of all countries in the world. In fact, when we look at men and women, women in South Africa have the highest obesity rate of all women in the globe. For many reasons. Some of it is just cultural acceptance, some of it is cultural desirability, some of it is lack of exercise. The WHO puts out tables of all sorts of things, and South Africa is one of the places which is the least active in terms of physical exercise. So for that and many other reasons, we have already a baseline weight propensity, and then we have what the people who entered the trial. Virologically, of course, dolutegravir did better than efavirenz, but that's not the point of this. So this is the graph that was shown, has been shown a few times. And again, just to orient you, the top line is TAF FTC dolutegravir, the middle line is TDF FTC dolutegravir, and the bottom line is TDF FTC efavirenz. And the magnitude of the weight gain is more for women than in men, although the order of the lines is the same. And so the real key question is, how do we interpret this graph? If you were to ask a question very simply, which is the weight neutral regimen on here, and which is the adverse effect? One way that the people who presented the trial seem to suggest is the efavirenz is the neutral arm, and dolutegravir causes weight, and TAF causes more weight on top of that. And that's certainly one way to interpret this, but it is also possible to say, is the TAF dolutegravir arm the neutral regimen, and TDF suppresses weight, and efavirenz suppresses weight? And what's fascinating is that interpretation, that we actually have two weight suppressive agents, is what we have learned in the past decade as a result of this and other trials. Gilead has about a decade of data, in fact, all the way back from the original prevention trials, to know that TDF has a weight suppressant effect around 2 kilos or so in some very large cohorts, including some very recent cohorts. TDF has a weight suppressant effect. And in this study, we also learned that some of you may remember that efavirenz is metabolized by a certain cytochrome, cytochrome 2b6, and that we differ in that cytochrome. And it turns out that slow metabolizers of efavirenz, and about a third of the population are slow metabolizers, those with higher blood levels of efavirenz, don't gain weight that as compared to people who are high metabolizers. The higher your efavirenz concentration is, the less weight you gain. Efavirenz has a weight suppressive effect. And so when we started to dig into the science of this slide, it looked like that the TDF efavirenz arm, the bottom line, actually has two weight suppressive drugs in that arm, and that the TAF arm, which I can summarize a lot of data by saying TAF, we believe, is relatively neutral. I'll go through some of that in this talk. TAF is neutral, and dolutegravir may be neutral as well, given some of the analyses, in fact, presented by the advanced cohort. So that's the key, is understanding which disease is the neutral arm and which is not. One last thing, and then I'll move on to the next slide. On the right is the weight gain. And when this was plotted as change in BMI at week 96, what's fascinating is that not one woman discontinued due to weight gain in this study. And when we started to understand more of the science of why that makes sense, it turns out that the BMI of women on average in South Africa is around 29. And these women entered, I just showed you, with a BMI of around 25, and over the course of the trial, their BMI came closer to 29, their societal norm. And so these women were in surveys, for the most part, happy that they had gained weight and now looked similar to their non-HIV positive women friends. And that understanding that there's way more to this than it looks has been really interesting science, both social science and medical science. And I hope I've captured some of that. Again, we can get into any controversies in the questions. But let me show you a little bit more about tenofovir. I've already mentioned some of this in my long discussion on that slide about the TDF weight suppressant effect, and therefore what you'd expect to see if you go off TDF, for example, on to TAF. And let me show you what I mean. So let's start with hepatitis B. Hepatitis B is a perfect place to start, since hepatitis B is TDF or TAF. There's no third agent, there's no second drug, there's no HIV. It's just TAF and TDF. And as you know, Gilead has both TDF and TAF approved for treatment of hepatitis B in many countries around the world. Again, I'm going to focus on the weight change. Look at the gray. The gray is TDF and weight. The orange is TAF and weight. And it turns out, as you can see here, that people on TDF lose weight. When they go on TDF, there's this weight suppressant effect. And on TAF, in year 1, they gain around 0.7 kilo. And in year 2, perhaps another half a kilo on the left study. On the right study, it's around 0.1, and then it leveled off. One thing about the background to know is that in the general population, if we just look globally in studies around the world, including those represented in these studies, people are typically gaining around a half to 1 kilo per year. In general, some people don't, some gain a lot more, but that's the average weight gain of the population globally. And that's exactly what the first curves look like here, is that on TAF, people are gaining around a half a kilo per year, which is similar to the background rate. And what's different is the TDF arm. To lose weight of 0.1 or 1 kilo and 0.7 is the unusual part. And this is one of many data sets to show that TDF has a weight suppressant effect. So it's not surprising that when people go from TDF off TDF, they will gain that weight. They gain the weight that was suppressed for as long as they're on TDF. One of the most common switches in medicine in the past 5 years has been going from TDF to TAF, because most clinicians agreed TAF looks safer. So one study that was presented to us just this past summer was a study from the US called the OPERA cohort. And they have a lot of patients who make a lot of switches. And so they focused in this particular analysis on the subset of people who are on a regimen with TDF. And all they did was go from TDF to TAF and maintain the other antivirals, again, virologically suppressed. And these are relatively healthy people. BMI is 27, so they're overweight, but otherwise they're not on any medicines to change their weight in any way. So you've got their baseline weight gain before the switch, that's the left side of the curve, and they're gaining around a half a kilo a year, as I mentioned, 0.42 kilos a year, and that's pretty stable. Then they go from TDF to TAF. In this study, they gain an additional 2 kilos. That's going from the 0.4 a year, now an additional 2 on top of that 0.4. So they gain the 2 kilos. And then on TAF, they go right back to the normal 0.3 kilo a year. So there isn't any weight gain on TAF that's excessive in our opinion. And again, there are many other data to support this. The TAF just happens to be the drug that most people use when they came off TDF and lost the TDF weight suppressant effect. And that therefore on TAF, you gain that weight that you were not gaining because of the TDF effect. And then you go back to a normal weight gain curve, because TAF doesn't cause excessive weight gain. TAF just allows you to recover from the TDF effect. And again, the TDF effect happens in about a year, and we can discuss whether that's a good thing or a bad thing, whether the TDF should be used as a weight suppressant, all those controversies. Nevertheless, the TDF weight suppressant effect is what we think is clearly represented right there one more time. Tango, however, is probably the best study to illustrate that TAF isn't associated with excessive weight gain. So Tango, hopefully you all know, virologically suppressed patients on a variety of regimens, study sponsored by ViiV, looking at continuing a TAF-based regimen or randomizing to dolutegravir lamivudine. So obviously no TAF. So shorter way to say it is continued TAF regimen or no TAF, dolutegravir lamivudine. And one of the goals of this trial, of course, was to document that something is undesirable about TAF so that you'd want to switch to dolutegravir lamivudine. Of course, that's one of the reasons to do this type of study, is that there's something undesirable about TAF. And one of the discussions in the field was, doesn't TAF cause excessive weight gain? Again, that advanced trial sure made it look like TAF might be causing weight gain, given that was the top arm. Many clinicians said, boy, that TAF arm makes me worry. So when you randomize people, and this is now those who are on an unboosted third agent, and I'll get into that in a moment why, but those who are on regimens of TAF unboosted, on the left side is the answer to the weight curve. At the end of a year, on TAF, people gain 0.4 kilo. On off TAF, they gain 0.8 kilo. There's no statistic here, so we can assume that there's no statistical difference. I'm not going to say that there's any difference here. These are two similar weight curves. But it's pretty obvious that TAF doesn't cause excessive weight gain, because you stop TAF and go on dolutegravir lamivudine, and you gain a similar amount of weight. I think this study, more than any study, documents in a randomized design that TAF isn't responsible for excessive weight gain. There it is. Now, I can show you, of course, the boosted subgroup, and the weight change is mostly the same. If you actually put the entire subgroups together, both groups gain 0.8 kilos. The only reason to show you the TAF-based unboosted group is to also illustrate on the right that TAF is not also responsible for any particular lipid changes. On the right are the lipid differences on TAF or off TAF. And you can see the lipid fractions are essentially the same. There is no significant difference in any of these differences. There's a small numeric difference in the triglycerides. It's not clear what that means. We haven't seen elevations in triglycerides in any other study, so it seems to be just a one-time finding for the study. Nevertheless, it's otherwise completely neutral in terms of lipids. So TAF has no role in excessive lipids. In the boosted subgroup, when you stopped a boosted regimen, there was an improvement in lipids, but not when you did an unboosted switch. So we think that that study actually helped document that boosters are responsible for lipid problems. And we agree, that's why Gilead developed BF-TAF. In any case, as you can see at the bottom left, there are lots of other metabolic studies that were done by ViiV, and they said, we don't see any difference between TAF or no TAF on metabolic outcomes. So we agree with ViiV. TAF is not responsible for excessive weight gain. Whatever you think is going on with weight gain in a patient, there's no evidence that stopping TAF will change the trajectory of weight change. You can certainly try it. Obviously, clinicians should do whatever they feel they must do, but there's no evidence from a randomized study that stopping TAF will lead to any different weight change. TAF seems to be an innocent bystander from these and other data. So that's the summary of this. There's no evidence of a causal effect. Weight change is happening in the population. TDF has a weight suppressant effect, and stopping TDF causes you to gain weight for that brief period of time. And oftentimes TAF has been the drug people have switched to. But there's also an issue of general obesity, and it's probably important to say, as is I'm sure true in all of your regions, that handling obesity and people who are overweight is a medical issue. It's not an HIV medicine issue, it's a medical issue. We all see obese patients. We all need to learn how to talk about better diet, more movement, particularly during COVID. There are studies that document many people are gaining more weight during COVID for lots of reasons, including eating more and drinking more. And as a result, we all need to talk to patients around how do we control weight through better diet and better exercise. So, mental health issues. So in this particular chapter, what I'm going to focus on is the concern for psychiatric toxicities of BF-TAF. So this slide has 3 different studies, all of which are switch studies. 1844 was a study for people essentially on Triumec, randomized double-blind stay versus switch. 1878 is a study of people who are on either boosted darunavir or atazanavir and randomized to stay or switch. And 1961 is a study of exclusively women, about 460 women, on either Genvoya or Scribbled or boosted atazanavir, again, randomized to stay or switch. Virologically, it always worked. In each study, BF-TAF worked, maintained non-inferiority in terms of the switch. So these are not registrational. These are just switch studies that we did in addition. So let's take a look at discontinuations due to adverse events in the naive studies I presented and now these switch studies. And as you can see, in 1489, as I mentioned, there have been 0 discontinuations through 144 weeks. And then you can see it's as high as 2% in one study, but the average in all of our studies is around 1% discontinuation. So 1% discontinuation rates. What are the discontinuations? Well, here are the studies in naive and then the switch. And as you can see, there are 1 or 2, and let's start with the N. In the N on the top here, we have just over 1,000 people on BF-TAF. So those with those side effects with an asterisk are those that the investigator thought was possibly due to study drug and linked to study drug in their assessment. So you can see there are 2 or 3 potentially neuropsychiatric adverse events in the top here. There's the 3rd person in study 1490 who had depressed mood and sleep disorder, and all 5 of those symptoms were 1 person. And then you can see the case of paranoia that's not linked to study drug, but there is 1 case of depression with an asterisk. And on the right is abnormal dreams. And there's also 1 case of schizophrenia. We've not seen that ever again. So in this study, we have about 4 out of 1,000 discontinuations due to neuropsychiatric events. And so 4 out of 1,000, or 0.5% or so, may be the rate of what we see in the background of people in general, but certainly that's what we saw in this trial. Certainly not a particularly high rate, 0.5%. You'll notice in dolutegravir regimens, it's perhaps 0.5 to 1%. There are more cases of depression that were linked to study drug in these trials. You can see that on the left side. But even in the case of dolutegravir, it looked to be around 1%. But that's the adverse events that led to discontinuation. We also know that some patients are willing to put up with adverse events. So this is the data here from a patient-reported outcome, an instrument called the HIV Symptom Index. It's a very simple questionnaire. Patients are asked about the 20 symptoms that you see, and they're asked how much it bothers you. And you can see the scale at the top of this so-called bothersome index. And the way that it's graded is you put together, I either don't have the symptom or I do, but it doesn't bother me, versus I have it and it bothers me. And that's the way this questionnaire is designed is, do you have symptoms that bother you? Because if they do, then your clinician might want to do something like change your regimen if you have a symptom that is bothering you, and it might be linked to study drug. So then what we did is we did this questionnaire at 3 different time points and looked for times in which there was a statistically significant difference in the frequency of bothersome symptoms. And if there was a difference in bothersome symptoms, which arm had more bothersome symptoms and which arm therefore had less bothersome symptoms. And what's fascinating in the double-blind trials in which this was done, the treatment-naive study of BF-TAF versus Triumec and the switch study of people on Triumec switching from Triumec or to BF-TAF or staying on it, again, in randomized double-blind studies. What's fascinating is that for all the symptoms listed, when there was a difference, people felt better on BF-TAF compared to dolutegravir, bacavir, lamivudine. And that's true for the top 2, which are what we call the GI toxicities, that nausea issue I mentioned on Triumec earlier. And then there's also the neuropsychiatric, the difficulty sleeping, fatigue, loss of energy, dizziness, depression, nervousness was higher in people on Triumec versus BF-TAF. And that was true in a double-blind significant manner and consistent for the course of the trial, for the course of the 48-week follow-up we had. So that's interesting, is that at least BF-TAF is better tolerated than Triumec in terms of how patients report. And a double-blind study, again, this is not biased patients. This is, I don't know what I'm taking, here's how I feel. And it showed up in 2 studies. So very interesting findings about these 2 drugs. This is a study that was presented in Europe within the past year or so. And this is a clinic in Germany that had a lot of experience with BF-TAF. So they reported what's the discontinuation rate in the so-called real world outside of trials for people on BF-TAF. And the table gives you the answers. You can see at the top row, they had about 943 patients on BF-TAF, so a lot of experience. And then you can see the percent discontinuing for any adverse event, 5%, or neuropsychiatric, 3%. And if you just run your eye down the column, those 5% and 3% numbers are very much the same in all the subpopulations they looked at until you get to the last row. And then you can see that people with a history of major depression discontinued BF-TAF 10% of the time, and they discontinued due to a neuropsychiatric event 6% of the time, as opposed to those without it, which was around 2%. So perhaps people who have a history of more depression may be more sensitive to BF-TAF, or just by coincidence might have a background of depressive events that happened while on BF-TAF and choose to discontinue to see if they feel better. You can't tell from a single site clinic trial if the drug is causing the side effect, because there's no comparison. It might be that 4% more people with depression feel depressed and want to just try a different drug in case it's the drug. We certainly can't tell because there's no comparator arm, nor do we have follow-up of how they felt after they switched. The bottom bullet also gives you one more detail, which is that there were some people who were on dolutegravir in the past who switched to BF-TAF, and you can see the numbers there. Of the roughly 40 to 50 people who switched from dolutegravir to BF-TAF for an adverse event, only 4 or 5 of them, only around 10% discontinued BF-TAF as well. So to put it simply, if someone is intolerant to a dolutegravir-based regimen, from this experience, there's about a 90% probability that they will tolerate BF-TAF as an alternative. These are not the same regimens, they're not the same tolerability, they are different, and there's a 90% chance somebody will tolerate BF-TAF if they didn't tolerate an bacavir-based regimen. And again, this includes the neuropsychiatric adverse events that were seen in either of the 2 drugs. That was the focus of these analyses. So then, I think this is the next slide, yeah. So now let's go to Tango. Tango, again, I mentioned earlier, randomized to stay on TAF versus switch. And in this switch study, this is the data that was presented to us, is that in this open label switch, some people had more adverse events on switch. And One of the things that people say is, well, of course, you're going to have more adverse events when you switch to a new regimen, since it's a new drug, and therefore a new chance for new antiviral activity, as well as new adverse events. And about 10% more people had adverse events on dolutegravir versus whatever they were on. As you can see in the next row, about half of that was grades 2 through 5. And so again, it's not always just mild in background. And in fact, 3% chose to discontinue due to having these adverse events. And you can see some of the reasons are this anxiety, insomnia, fatigue stuff certainly can happen on dolutegravir. So one thing that we've shared and some clinicians have shared is, well, of course, you're going to have more adverse events when you switch. Anytime you switch, you'll have more adverse events. And that's not always true, but sometimes true. When you switch, you have more adverse events, but sometimes you have less adverse events. It depends what you're on and what you switch to. And again, this is the drug-related adverse events in the treatment-naive and switch studies that I just mentioned. 1844 is a switch study in suppressed patients on dolutegravir, abacavir, lamivudine, randomized to stay on it or switch. So feeling reasonably well because they signed a consent form saying, I'm okay staying on this another year. And yet, as you can see, there's the statistically significant difference, statistically significant difference right in the middle of your curve in the slide, that people felt better when they switched versus stayed in this double-blind study. People felt well enough on dolutegravir, abacavir, lamivudine to stay on it. These were not people who said, I need to come off this drug. They were willing to stay on it in a trial. And yet, if they, in a double-blind way, switched, they felt better. They had fewer, significantly fewer drug-related adverse events. So it isn't always true that you have more when you switch. Sometimes you have less. It depends what you're on and what you switch to. So we then have our real-world trial. This is the Big Star cohort. This is a large open-label study. We're just following a cohort of so-called real-world outside of clinical trials and just monitoring the lives of people who are either started or switched to BF-TAF at the discretion of their physician. So as you can see here, at this point, at this analysis, we have 613 people in Europe, Germany, France, Netherlands, Ireland, and also Canada was represented in this analysis. And as you can see, in terms of the left side of the curve, some of the characteristics, I'm just going to bring your attention to the bottom comorbidities, since 16 or 26% had neuropsychiatric disorders at baseline. I mean, 75% had one or more comorbidities. Perhaps that's true in HIV medicine these days, but 26% of the treatment experienced persons had neuropsychiatric disorders when they entered this study. So clearly, this is a part of the background of our field these days. There's a lot of insomnia, anxiety, fatigue, depression, and so on. Absolutely something to keep in mind. And on the right are some of the regimens people were on when they entered. If they were already treatment experienced, about a third were on dolutegravir, as you can see in the middle group, and about half on TAF. So then what happens? So at 6 months, which is the longest that this cohort had available follow-up for, 99% of the treatment-naive persons, as you can see on the left, were still on it at the end of 6 months, and 95% were still on it if they were treatment experienced. The reasons that some of the treatment experienced persons came off is in the middle box. There's one discontinuation in the treatment naive, but there are 21 or 4% who discontinued if they were treatment experienced. And most of that was considered drug related. And there was one who discontinued for weight gain, although I will point out that this is a person who switched to BF-TAF after stopping efavirenz and TDF, two weight suppressive drugs. So perhaps not surprising that they gain weight when they stop weight suppressive drugs. At the bottom in a footnote are the other adverse events that contributed to discontinuation. And again, since the treatment experience study has about 500 people, what you can say is that about 1% headache, 1% nausea, maybe 0.5% fatigue, 0.5% depression, 0.5% sleep disorder, and so on. So we would definitely say that there is 0.5% of some neuropsychiatric events happening in these people who 26% of whom had neuropsychiatric events when they entered the study. So whether the drug made it worse or not, hard to say, but obviously some patients chose to discontinue to see if they felt differently on another agent. Perhaps one of the limitations of these data is we don't know what they go on next and if they felt any better stopping it or not. But this just gives you a snapshot of what we're seeing in practice as well. Still around 4% discontinuation in real world cohorts. So in mental health issues, I'd summarize by saying there is some psychological distress in the population. As we know, lots of depression, anxiety. It's difficult to have HIV infection in many countries around the globe. Two double-blind trials that we have that have the patient-reported outcomes show significantly lower prevalence of these bothersome neuropsychiatric symptoms in BF-TAF versus dolutegravir, bacavir, lamivudine. There clearly are some antivirals that are implicated in neuropsychiatric toxicities, and efavirenz is probably the most famous of all. But in the switch of BIC and dolutegravir, that the study from Germany would suggest that of those people who are on a dolutegravir-based regimen and who switch for an adverse event, including neuropsychiatric adverse events, about 90% of them will not have a recurrence of the neuropsychiatric adverse event, that they will tolerate bictegravir about 90% of the time. So, cardiovascular disease. And does TAF have any role, does BF-TAF have any role in worsening the cardiovascular profile of patients? So these are the lipid data from the treatment naive studies. And as the way that these slides work, again, the green is BF-TAF, the other are the dolutegravir regimens. And the darker line at the top is the increase in lipids that you see when people start treatment. So people start, for example, with a total cholesterol of 157 or 162, 161, and they increase around plus 10 to 13 over the course of time. One thing to point out is these lipids are actually remarkably low. Again, an LDL of 100 at baseline is already low, and going from 100 to 114 or 120 is still relatively low risk for the population. The other interesting and important thing to point out is HDL, which hopefully you all know HDL is the good cholesterol. HDL is the protective lipid fraction. HDL improves when people go on HIV treatments, at least with these HIV treatments. HDL improves in addition to LDL. And that's why Gilead strongly believes that the total cholesterol to HDL ratio is the most helpful predictor. And as you can see, the total cholesterol to HDL ratio started around 3.4 to 3.7. And over the course of the trial, essentially you wind up in that same place. There really isn't much movement in the ratio at all, even though there's a highly significant statistic between 3.4 and 3.7. Again, in terms of outcomes and predicting the next 10 years of heart attacks, there isn't that much difference between a score of 3.4 and 3.7. And of course, that 3.4 is on a bacavir-based regimen, which has its own cardiovascular related toxicities. So it certainly wouldn't be the ideal drug, even if you prefer to have a 3.4 instead of 3.7. So why is Gilead so confident that the ratio is the better predictor? And these are data from the cardiovascular literature. This is not an HIV study, but the cardiovascular literature has actually some large cohorts that say that the ratio is a better predictor than LDL. So what you're looking at here is, again, a large cohort. As you can see, 14,000 participants who have no cardiovascular disease at baseline and have lipids for an average of about 24 years of data, and trying to figure out what predicts events. So in the table, the top, people with a low ratio and a low LDL, have a rate, as you can see, of around 6.5% of people had a cardiovascular event over time. So that will be the baseline of people with low lipids, low ratio, low lipids. And again, a low ratio is the good thing here because that means your HDL is a lot of your total cholesterol is HDL. So if you then look at people with a high ratio, people with too much cholesterol to HDL, so their HDL is relatively lower, then as you can see, the risk for events goes up by double. They have now 6 to 11. And then when they do the math in their modeling, it's around a 25 to 50% increase in people who have events by an increase in the ratio, but they have a low LDL. Now flip it the other way, the next row. If you have a high HDL but a normal ratio, you have no difference in the rate of events. It's the same as people with a low LDL. An isolated high LDL has no impact on the risk of events. It's only when you have a high ratio that you have a high risk of events. Indeed, if you look at that bottom row, having a high LDL in addition to a high ratio increases events, but not that much more than if you have a high ratio but a low LDL. So LDL really isn't all that predictive for future risk of events in this very interesting European study that was done and published just last year. So it seems pretty clear that Gilead should pay attention to the ratio based on these data. Now, in a recent conference, there was a group in the Netherlands that presented a question around TAF. And so let's just take a quick look at their data. They showed that in this, again, cohort, there's no randomization here. They had been using TDF in a lot of patients and started to use TAF and then looked at what was happening. And on the right gives you some idea that the TAF, which is the blue line, only has a very short period of follow-up, about 2 years as compared to the other regimens. And then they started to look at the number of cardiac events. And you can see a separation in the Kaplan-Meier curve at the top here with a highly significant p-value of 0.001. So they then gave us more detail. And the left is a table of some of the hazard ratios for cardiac events by other risk factors. And you'll notice a couple of things that make sense, some that don't. They find that female gender has no difference than male gender, and that doesn't always fit the data. Usually men have a higher risk than women, but they didn't see that in their study here. In any case, looking at the right is kind of what they said is their concern is TAF versus no tenofovir, fourfold increased risk of cardiac events, and TAF versus TDF, twice the risk. And they said they controlled for things they could control for. Of note, they didn't control for things like diabetes and hypertension. And the reason I point those out is one of the reasons to use TAF instead of TDF is renal impairment. Certainly in the Netherlands and elsewhere, the clinicians agreed TAF is better for people with impaired renal function. I should use TAF instead. And if you're going to use TAF instead in renally impaired hypertensive patients, those patients are at higher risk for cardiac events since renal disease increases your risk of cardiac events. And unfortunately, they don't control for that in the channeling of who went on TAF instead of TDF. So it may be part of the problem is you're channeling people onto TAF who have a higher risk of cardiac events because TAF is safer than TDF in terms of renal disease. But the other thing about this trial that I think is worth pointing out is what do they mean by cardiac event? And what they meant is arrhythmia. That's the only one with a significant p-value. There was no difference in angina, no difference in cardiomyopathy, and no difference in myocardial infarcts at all. The only thing that was increased is arrhythmia. And we're not sure what they mean by that. We don't know if that means atrial fibrillation, if that means ectopy. We really don't know. From the poster certainly doesn't tell us. And we're obviously working with the office to try to find more. All we can say is in our databases, in all of our studies with TAF versus something else, we don't see an increase in arrhythmias at all. And we've got now 5 to 6 years of TAF-related data and a lot of clinical trials and a lot of real-world experience. And we haven't heard anything about a signal of arrhythmia in any of the cohorts. So we're not sure what to make of this other than we're working with the office to try to find out what they mean by arrhythmia and understand what they're seeing a little bit better. What we can say is we've stress tested the TAF-based regimen. Probably the most we did was in this study. ECF TAF or Genvoya, the first TAF-based regimen, was evaluated in people who were at high risk for cardiac events because they had kidney impairment. They had a GFR between 30 and 70, and that's of course impaired renal function. And people with impaired renal function are at higher risk for impaired cardiac function. And at the left, you can see that there were 15% diabetics, 50% hypertensives, and so on. And the right is the single-arm virology. They certainly did well in terms of maintaining virologic suppression. And the most common adverse events, as you can see here, were nausea, diarrhea, and arthralgia. But we saw no cardiovascular signal at all through 3 years of follow-up. So, and in fact, no participant discontinued in the 3rd year of the trial. So we don't see an arrhythmia signal. We're not even seeing a cardiovascular signal or concern with TAF. And so, again, we think so far the data are pretty clear that TAF is a safe regimen for people with any kind of cardiovascular concern. So randomized trials show the issues that the total cholesterol to HDL ratio is very similar, whether you use TAF or TDF or TAF with bictegravir, TAF with dolutegravir. And we think that the ratio is the most important, most proven way to monitor the risk of cardiovascular events based on the cardiac literature. I mentioned the arrhythmias that we don't understand what they mean by that. We certainly don't see that before. And then study 112 I just shared with you that doesn't see a concern. So modern triple therapy versus 2 drugs. Another controversy is how many antivirals should I use? I'll have to speed up a bit to make sure we have time for your comments and questions, but here we go. Currently, in 3 sets of guidelines, we have several choices that are recommended to start treatment, all of which are integrase-based. As you can see, some of them are single tablets like BF-TAF, which is in blue, also recommended for rapid start. And then we've got some dolutegravir regimens as well. And of note is, I'll just make a couple of other comments on the IAS USA. They've actually no longer recommended dolutegravir, abacavir, lamivudine. That's gone. They think TAF is superior to TDF, or TAF and TDF are superior to abacavir. So they've gotten rid of the abacavir-based option for dolutegravir. But as you can see, all 3 guidelines now do mention dolutegravir, lamivudine. albeit with restrictions or limitations in the patient population, either avoiding the highest viral loads, cautions in the low CD4 group, knowing hepatitis B co-infection status, knowing the genotype resistance portfolio before you start, and some monitoring. So there's some additional language on dolutegravir lamivudine, but at least it is on their list at this point. So how might these regimens differ? And what do we at Gilead think? Because Gilead obviously could have developed the two-drug combination of bictegravir and either of the nucleosides. We certainly could have, and we chose not to. And we still think that a three-drug combination, such as BF-TAF, makes sense, even with the data that we'll share. So the first is resistance. In all of these three-drug regimens that we've studied over the years, including the two on BF-TAF versus any of the others, we've not seen any treatment-emergent resistance. And certainly, I'm doing this HIV long enough to remember when you do get treatment-emergent resistance and you run out of options, you can run out of treatment options after a few failures. It certainly could in the bad old days. And that was a scary thing to face because salvage therapy, so-called salvage therapies, could be complicated and weren't always successful. And so one of the things that Gilead really believed in is we want a pill that has the potential to last for somebody's life. We don't want a pill that will fall apart in a couple of years. We want something that clinicians could have confidence in, that their patients could have confidence in, that if they feel well enough on it, that it will work for the rest of your life. And so avoiding resistance was one of the goals of creating bictegravir. And so far, after 3 years, we've not seen any treatment-emergent resistance in any of the clinical trials. It doesn't mean it can't happen at all in stress tests, but it does mean we haven't seen it in our clinical trials, and we have a large clinical trial pool. However, there are two cases of treatment-emergent resistance with dolutegravir lamivudine. This is the first from the phase 2 study. Treatment-naive patient went on dolutegravir lamivudine, had suppression by week 4. At week 8, they rebounded. The clinician investigator said, restart your regimen. It's a good idea. And their viral load gets to around 400 copies. But unfortunately, by week 16, they have two-class resistance. And this was certainly the first two-class resistance that we had seen in a while, happening in the first 24 weeks. And I can tell you that I was sitting with the leader of our clinical research group when we saw these data at the Paris meeting. And that was one of the key moments for him, which is, I am not going to develop a two-drug regimen with BIC because I don't want to lose BIC. And they just lost dolutegravir. And whether that happens once or happens more, we just didn't want to chance losing bictegravir. FTC and TAF are good drugs and safe drugs, and why would you take the risk? So that was the beginning for kind of Gilead's stance, and this was this one case. Gemini, you're all aware, is dolutegravir lamivudine versus dolutegravir and Truvada, and these are the patients that they studied it in. We just saw the week 144 data at the virtual Glasgow conference, and it maintains non-inferiority at the end of 144 weeks. At the very right of your slide is the controversy around the lower performance at the lower CD4 count. And at least one of the guidelines comments that that's a cautionary note for the use of this in patients with a lower CD4 at baseline. So one of the things about this trial is that they have said that there is also no evidence of resistance until this year. In blue, there was actually now the second person in two trials who's developed two-class resistance. As you can see in blue, a person with erratic adherence, which certainly happens in life and in trials. That person was suppressed for 2 years and then had a period of non-adherence, viral load of 60,000, developed 184V, and soon after added the integrase mutation 263. And again, that certainly confirms for us why we believe in a three-drug approach, that these two just may not be robust enough to work for everyone for the rest of their lives. The only other point I think I should make on this slide is this confirmed virologic withdrawal. What that means is if you have a viral load greater than 200 twice, you're removed from the trial. They don't leave people on this regimen who are low-level viremic at all. And again, that's a good idea if you're nervous about your regimen. Certainly as a new regimen, you should be nervous, but that isn't necessarily clinical practice. If somebody is greater than 200 twice, you might do adherence counseling or encourage them or do whatever you do. But stopping somebody after the viral load is over 200 within 2 readings in a month is not exactly clinical management, certainly not in the US. And this regimen wasn't stress tested. The only other last point I should make is that ViiV only tests the first sample in these confirmed virologic withdrawals. There's the first sample that's greater 200, and then there's the confirmatory. And the confirmatory sample is usually 4 weeks later, but we only have resistance test data from the first sample. For whatever reason, ViiV doesn't run the second sample, even though the second sample theoretically could have more resistance, since after all, the person's been viremic for an additional 4 weeks. In the first sample, we've not seen any resistance in any of these virologic withdrawals, but it's certainly unclear whether the second sample might have anything that's missed by the first sample. And that's just one of the question marks for these data sets. And then we just take a look at the meta-analysis of real-world data on ditegolamivudine. Is stopping a drug like TAF, TDF, et cetera, going to make everything all fine again? And what we point out here is virologically, people are doing okay, 1 to 2% virologic failure, but 12 to 15% are actually discontinuing the regimen for whatever reason. And this is a meta-analysis that ViiV helped put together based on 12 studies of over 3,000 people. And so again, there is some discontinuation rate on this regimen. Just stopping that second nucleoside doesn't make everything go away. Still, there's some discontinuations going on for people. I've already presented this part of it, so hopefully spent enough time earlier. In the interest of time, I'll skip it. And the only other point I think I should make is the TANGO study. So when we go to 2 antivirals and maintain virologic suppression of HIV, does that mean everything is the same? This is data again from ViiV, and they said, well, we noticed a significantly higher IL-6, interleukin 6, as when people switched to 2 instead of remained on 3. And some of you may know that IL-6 is an inflammatory marker that's been studied in HIV medicine and in medicine in general for easily over a decade. And IL-6 is often correlated with an increased risk of negative clinical adverse events, particularly cardiovascular events, but other events as well, and reported this 16% increase in IL-6, even though the HIV viral load is suppressed to undetectable. So why is there increased inflammation? I didn't show it on the slide, but this is actually the second time they also showed higher IL-6 in people who went to the Juluca regimen. So again, when you went to 2 drugs despite virologic control of HIV, there's higher markers of inflammation of IL-6 in both regimens. And it's not clear what that means, but we actually have a third study from Spain that also reported that there's higher IL-6 and other inflammatory markers in people suppressed on 2 antivirals. And the question is, why is that and what does it mean? In any case, we've studied BF-TAF in a lot of patients, in a lot of subsets of patients, and we think we've got a robust regimen with a lot of data to reassure clinicians that this is a good, safe regimen that will work for your patients to keep them well. And the last quick section is, should I rock the boat? The viral load's undetectable, everybody's happy, what's the big deal? Why should I switch? These data are actually come from a ViiV-sponsored survey in which they asked people with HIV, and as you can see at the top, there's a lot of people who responded, almost 2,000. And what they said is, in red, these are my priorities for the next 2 years, side effects, transmitting, and so on. And then the third said, I'm actually uncomfortable discussing side effects with my clinician. So one question for all of us is, if my patient says everything's fine, does that mean everything's fine? Or does that mean a third of them actually have something that they don't feel fine about, but just don't want to tell us for whatever reason? And that's one of the questions here. So we did a study in the US, relatively small study of people on Atripla, doing well on Atripla, have been offered switches off Atripla in the past and said, I'm okay on Atripla. And then we said, well, how about BF-TAF? We think it might be different. Let's see what you think. Virologically, it worked. But what was remarkable is that people who felt well on Atripla felt better on BF-TAF. All of these symptoms here, including the sleep stuff that's famous with efavirenz, people felt better. And this is common for clinicians to say, I feel better off something, even though I didn't know I had a problem on it. So again, if somebody switches and they don't feel better, they can always switch back. But sometimes it may be broke, even though somebody isn't complaining. I've already done these questionnaires for you, so I won't reiterate. People felt better in the switch off Triumec as well. Again, people thought it wasn't broke, but then when they switched, they felt better. People can feel better, and I've shared this slide with you earlier. The last point I'll make is on single tablets. These are US data, and just to be brief, what they found is that adherence to the single tablet BIC, and that's the bottom row here, was twice as successful to be adherent to a single tablet BF-TAF versus the multi-tablet dolutegravir plus 2 nucleosides. So dolutegravir Truvada, for example, there was twice as good adherence on one tablet instead of two. And we often think as clinicians that one tablet, two tablet, what's the difference? But these data say, and there are other data like this, that there is a difference. Some patients are just better at taking one tablet than they are taking two. And in the bottom, it says that in fact, people who are adherent are more likely to be virologically suppressed. So that of course makes sense. So we would say that, again, if one of the ways it may be broken is multi-tablets, and if it's a single tablet, it may be worth considering, since some people are better at taking a single tablet versus a multi. So I'm going to stop there, stop sharing, and see what questions we have time for in our chat.
Thank you, Dr. Karl, for excellent presentation. It looks like we don't have any questions in the chat box, but I would like to invite you to ask now. So, are there any questions from the audience? Please just unmute yourself and...
Yes, please ask anything, anything at all. Your hardest question.
Okay, maybe I'll start. So my name is Janis Tomažić. I'm coming from Slovenia, Ljubljana. So in the era of integrase inhibitors and TAF, we observe patients with weight gain, especially, I would say now, in the period of COVID-19. There are reasons for that. So what do you think excessive weight gain? We don't know the mechanisms, as you mentioned. There's better appetite, probably they're multifactorial. But is excessive weight gain connected with diabetes, hypertension, premature death? That would be my question.
Excellent question, thank you. Very important question. So we actually, I didn't show the slide, but we analyzed exactly that from the randomized trials that Gilead's done for the past 15 years and saw no difference in incident diabetes or lipid problems or hypertension in those who gained at least 10% of weight compared to baseline. So we have to draw a line of what are outliers. So we picked 10% from baseline. And that's, again, if you're 70 kilos, that's another 7 kilos. So that's a fair bit of outlier, and 10% or more. So there are some who gain even more than that. And we don't see a difference in the clinical diseases that we associate with obesity, which is interesting. And we're not the only cohort. There have been some other presentations in the past year that say the same thing, that predicting the outcomes based on equations of obesity would be a little scary because obese people have bad things happen, but we're not seeing it in the actual patient experience. And it's not clear, again, why that is, but it is fascinating and at least reassuring. I think then it leads to then what do we do? If you just say, all right, I don't have to worry about this causing diabetes, at least not so far, what do I do with someone who's gained more weight than I think is healthy? Whether we think it's their antivirals or COVID-19 and drinking and eating too much and not moving, what do I do? And I think usually the biggest questions for clinicians are, should I change antivirals? And what else can I do other than that? As I mentioned, the only randomized data we have now is the TANGO study. And TANGO showed no benefit of switching antivirals and weight trajectory. So, and while there are a lot of other switch studies that have been presented in this past year, about the only thing we can say is that when you stop TDF, you'll gain the 1 or 2 kilos because of the TDF switch. That we think is clear. That doesn't mean we should use TDF as a weight suppressant drug, because TDF has other side effects like renal disease and bone disease. And perhaps an important nuance is in that advanced trial, that one that showed the differences, the difference in weight, they did DEXA scans. And it turns out that the ATRIPLA arm, they didn't gain that much weight, but what little weight they gained was all fat. In the TAF FTC dolutegravir arm, they gained lean mass as well as fat. And we all believe that lean mass is a healthy gain, muscles and so on. So it looks like TAF allows you to restore kind of normal weight gain, whereas TDF suppresses lean mass gain, which probably isn't a healthy thing. So we certainly don't think TDF should be used as a weight suppressant drug. And besides, it's only about 1 kilo or so. What you really want is something more effective than that. And right now we have no randomized data to support that switching antivirals will help you lose weight in a good way. So what does that leave us? That leaves us with everything else you do in medicine, which, I am an internist by training, and I probably spent 20% of my medical visits with, you weigh too much, and you have diabetes, and what do you eat? And can you eat less? And no, be honest with me. No, tell me about the potato chips you eat while you watch TV at night. Tell me everything. And after they don't tell me everything, bring your wife in. Let her tell me everything, because I know you're not telling me the truth. And let's discuss honestly what you eat. And let's see if we can stop the McDonald's and fast foods. And let's see if we can have you eat some healthy things and lower calorie things. And maybe take a walk in the morning and take a walk at night, whatever it is. Just COVID-19 is documented to make all of this worse. There's about a 50% increase in alcohol and about a 100% increase in people eating comfort food and candy and stuff. No surprise, but that causes weight gain. And we have a whole literature on helping people lose weight. It's hard to do. People don't like to give up their favorite foods. But unfortunately, that's the most proven way to truly have long-term weight suppressing, is to change what we eat and how much we burn. And unfortunately, it's as simple as that, but it's as difficult as that. But thank you for your question.
Can I have another question? Tomasz Wołkow from Ljubljana. So I would like to talk about resistance, which is I really like it. So you mentioned, thank you for the data. It was really nice to hear about those two resistances. But so the 263R resistance is not such a bad, it's not a really critical thing for reticular anyway. But so it's still, don't you think, if you have all the data, all the people, all the double therapies, and then just in two resistances, do you think it's really important that much? Or so maybe we should have some more data, some longer follow-up. So what's your view on that? Because we were thinking about patients that are really they have really good adherence, that really you can talk to them, that they will say, sure, I will never miss, and they never miss. And so I have a lot of these patients, and I said, why use triples when you can do with double therapy? So this is my thinking, and I'm just I want your comment.
Thank you for that. That's great. So I absolutely agree that 2 cases of resistance is not the end of the world. I do think 263 undermines the activity of all the 4 integrase inhibitors. It certainly doesn't make them better, right? It only makes them a little less powerful. And again, we're talking about suppression for decades and decades. So I think 263K is at least on the list of mutations that injure the activity of the important integrase inhibitors. So I think it's at least a consideration. And 2 cases is 2 cases. You may be aware that at the virtual conference we had in Glasgow, that a clinician in Germany presented a case of 2-class resistance on BF-TAF in his clinic. A patient with a viral load of 2 million PML, a CD457, and over a period of a year developed 2-class resistance. So again, erratic adherence and high viral load is a terrible recipe for any regimen, and BF-TAF lost to 2-class resistance. And so that's one case, and we have 600,000 patient years, so resistance can certainly happen. But I think that's my point, which is resistance can happen. And we want to make sure these patients have a lifetime without worrying about resistance and what to do about it. And it makes, to me, biological sense that if you can see resistance to a 3-drug regimen, and there are cases of resistance to Triumec. We now have this case of resistance to BF-TAF. I mean, they're 1 cases, but it certainly can happen to 3. So if it can happen to 3, it's certainly more likely to happen to 2. I mean, just biologically, if you remove an antiviral, you're making the regimen more vulnerable to something going wrong. I mean, this virus wants to win, and it will. If you get a flu or a COVID illness and you get massive stimulus of CD4s and CD8s growing, if the virus is growing and there's incomplete drug taking, if somebody's not adherent that Thursday, it's just more vulnerable. And Gilead certainly presented in vitro data that 2 are more vulnerable than 3 to viremia and breakthrough, albeit again, a model that is predicting the future that so far looks reassuring. But the only other thing I would say then is, in terms of the worry of the long term, is, as I mentioned, first of all, ViiV has not presented the resistance of the second sample. And so we're not sure how much resistance there might be. All we can say is there wasn't in the first sample, and I'm not sure why they don't do the second sample. That would certainly reassure me as well as you that there really isn't anything yet. Assuming there's really nothing there either, again, we're 3 years into the story, what else is there to worry about? Well, over time, there certainly could be resistance. There's two more things I would say. One is we know that when we switch, some patients have a history of the 184V mutation just because we use 3TC and FTC a lot. And 184V is the most common mutation to be there, whether we know about it or not. It's just, that's the mutation that happens during erratic adherence in regimens with 3TC and FTC. And if they are suppressed when you see them and don't know about the 3TC or FTC, there's a test you can do, but it isn't commonly done in clinics. And that will only make the 3TC or FTC less fully active, which means all the pressure in dolutegravir on dolutegravir. And 2 years ago, we saw about 3 or 4 studies which showed that dolutegravir monotherapy yields to dolutegravir resistance. So it's a little worrisome if somebody has underlying 184V, and maybe it's just a matter of time before some of them will lose their dolutegravir. Certainly, that's the risk of using it in that circumstance. And we don't always know if somebody has 184V unless you use proviral DNA testing. The last point I would make is this concern about inflammation, since there are now 3 studies in a row that show that even with an undetectable viral load, after a year or 2 or 3, the markers of inflammation are higher on 2 than 3. It's higher on dolutegravir rilpivirine, it's higher on dolutegravir lamivudine, and higher on other 2 drug combinations. And all 3 studies in a row said something is different, and markers of inflammation are higher for a reason, and I don't know why it's higher. I don't know where it's coming from. Nobody does, but it is there. It is different, and it isn't a good thing. IL-6 is never a good thing. It's up for some reason. And I think until we understand that, we should understand that this regimen has been proven in some ways, but it raises another question mark, which is, what do we do with that? And again, Gilead is not against 2 drug combinations. We actually have a 2 drug regimen arm in our experimental drug called lenacapavir. We have a 2 antiviral combination, and the team are going to get inflammatory markers to see if 2 suppress HIV, but don't completely normalize inflammatory markers, then it's not all the same. So that's a long answer to your question, but I think a lot about this because, again, Gilead is getting involved in studying 2 antivirals because we think we have 2 good ones. But I think that there's still reasons for caution as we think about patients over decades. And I guess that's what I come back to, partly because I did HIV medicine for decades, and I know what it's like to run out. And we have more drugs than we used to, and these drugs are better than they used to be. So running out is unlikely. But nevertheless, it's never good to see a 263K. I'm never going to say, boy, that's good news. Lucky you, right? It's always bad. And that's why Gilead as a company wanted to develop regimens in which you would almost never have to say that. That was our approach.
Maybe another short question. What would be your opinion concerning TAF as a lifelong time period? What would be the weak characteristic of TAF?
Yeah, thank you. Great question. So I joined Gilead almost 6 years ago when TAF was just finishing its phase 3 trials. I joined in part because I thought TAF looked like a great drug and a great antiviral, and gave me a chance to do global medical education and on the TAF portfolio. So I certainly have been watching this drug for 6 years. And what I would say after 6 years is that even though there's a lot of controversy now around TAF and excessive weight gain, again, based on the TANGO study alone, and there's more than the TANGO study, but based on ViiV's randomized data, TAF doesn't seem to be responsible for the excessive weight gain. There are people with excessive weight gain. Absolutely, there are outliers, and I agree with you, they are a worry. What's again fascinating is that there are outliers of people who gain a lot of weight. There are actually outliers of people who lose a lot of weight on the same antivirals. So it is clearly too simplistic for us to say as scientists, this regimen causes weight gain, because so a quarter of the population are losing weight. And so how do I explain that both things happen? And the short answer is, we're not sure how to explain both. All we can say is it's too simplistic to say this drug causes weight gain, because it doesn't always. But there are these outliers. There are these percent of people who gain a lot more than others. And Gilead has a whole team of people trying to figure out if there's anything we can figure out to explain it. most likely it'll be some genetic difference, because as you know, genetics explains almost everything these days. I don't think it'll be as simple as they just eat more. I don't think it's going to be something like that. I think it will be some genetic difference. And what that does, how does that turn into excessive weight? I don't know. But I don't think TAF will be responsible for it. I think TAF might be used in people who do gain a lot of weight, but I can show you curves in which people take TAF and lose weight, and it's the same drug. So I don't think TAF is responsible for this weight gain story. And I think, again, as I showed you, I think the lipids are neutral and we don't see a cardiovascular signal. And we certainly haven't seen a renal or bone signal. We don't see any of the TDF stuff. And that's 5 or 6 years, right? We haven't seen a case of Fanconi syndrome that can be attributed to TAF. The few cases that have been reported in the literature are people with very complicated nephrotoxic conditions in whom a nephrologist said Fanconi could have developed without TAF at all here. So we haven't seen anything in which somebody has said, aha, that's TAF. I mean, other than, you know, the usual 5% of people have a little nausea or headache or something. In all those studies that we have with BF TAF, again, 1% discontinuation. And there isn't like that 1% is all one thing. It's, you know, it's like 1 in 1,000 with depression, 1 in 1,000 with sleep disturbance, 1 in 1,000 with this and that. So it's a headache. So it's relatively rare events. So I guess what I'd say is we don't know. I don't think we know what the signature long-term toxicity is for TAF yet, because it's not showing up. Again, ViiV tried to identify that for us by doing a randomized study and stopping TAF, and they didn't find one either. So thanks to ViiV for confirming what we thought, and that's helpful when a competitor company says the same thing, which is we don't see a TAF signal here. So I don't think we know. I think in 10 years something might show up, because something, you know, long-term is longer term. You can always say that. That's safe in medicine to always say longer term data will tell us something. But so far so good. And believe me, I joined the company to be the TAF guy, and I keep a watch for it, because if anybody should know, I should know it first. And so far I don't see the issue yet. If there is something, I'm sure Gilead will be the first to share it.
So good data always translate in guidelines. And how would you comment that 3-drug regimen is no more preferred regimen according to 144 weeks Gemini data?
Oh, you mean so dolutegravir gets added to the guidelines? Yeah, no, I agree. They have shown virologic non-inferiority. I mean, the data are the data. They have virologic non-inferiority for 3 years, absolutely. And they deserve to be a potential use for treatment-naive patients. The guidelines do have some caveats. Again, there aren't data with very high viral load. Low CD4 is a question mark. It isn't the ideal regimen for rapid start. If somebody has hepatitis B co-infection, lamivudine is not the ideal drug for hepatitis B. So there certainly are some limitations to it. And then the question is, the guidelines say that there are 3 drug options and 1 2-drug option, but they don't say you should pick the 2-drug one. They say you have a choice of a couple of 3s and 1 2. And then the question is, how do you pick between them? Do you pick a 2? Do you pick a 3? I mean, I think at the moment, what I would say is that it just makes logical sense to me that starting with 3 will certainly get virologic suppression and avoid any chance of erratic adherence. And why risk it in the first 24 weeks? We hardly, you know, we don't know the patient that well, get their viral load undetectable. If they're suppressed and all is well, as your colleague said, could I use 2 instead of 3? And the switch data would say you could, but number one, why would you want to? What's the benefit of stopping TAF? If TAF is helping maintain virologic suppression without toxicity, what's the benefit of stopping TAF? And is the inflammatory marker difference telling us that 3 are doing something that 2 don't do as well? I'll tell you one of the hypotheses that is interesting, though it's, again, just a hypothesis in why there's higher inflammatory markers, is that there are published data that tenofovir is partially an anti-inflammatory. So maybe you're stopping an anti-inflammatory drug, and that's why the current 2-drug regimens show higher markers of inflammation, which then leads to what would happen if you did a 2-drug regimen with tenofovir in it? Would you have virologic suppression and lower inflammatory markers? And the answer is I have no idea, but it is interesting that all the 2-drug options that have been studied, all of them stop tenofovir, and they all see this elevated IL-6, and there's a publication that IL-6 is lower, or inflammatory markers can be lower because of tenofovir, and that's in HIV negative people. That's not an HIV study. So just interesting pieces of the puzzle.
Oh, sorry, what will you combine lenacapavir with long-acting tenofovir, or?
Well, thank you for your question. So the first studies that are being done now are so-called salvage. Lenacapavir combined with optimized background, whatever you want, right? Twice daily darunavir, whatever, right? You know, those patients. Going forward, we're doing a study in treatment-naive persons, and the initial randomization is lenacapavir, which hopefully you know is being dosed subcutaneously every 6 months, and a standard 3-drug regimen. In other words, lenacapavir is one of the 3, and then the other 2. And usually the 2 are FTC-TAF. So we're going to just use the standard approach for now. However, that study then has a follow-up randomization for going from FTC-TAF lenacapavir to lenacapavir plus either bictegravir, so just those 2, or lenacapavir TAF. So that's those 2. We have no results of that yet. We don't know what's going to happen. I have no idea, but we're certainly open to the concept that if, let's say, you know, long-acting TAF, long-acting bictegravir, long-acting molecule X, and long-acting lenacapavir are enough, then Gilead is all for simplicity and all for safety and all for, you know, the different world it would be if an antiviral regimen was, here's your subcutaneous injection that you can do at home, and you don't have to take a pill, and come into the office every X weeks and we'll see how you do it. Gilead wants to be a part of that innovation as well. Even though a pill a day is pretty easy. I mean, a pill a day is pretty easy compared to the old days. But sure, if you could do a subcutaneous injection at home every X weeks, then why not?
Hello. My name is Gabi Turil. I'm coming from Slovenia also. I just have another question about the weight gain. I was just wondering what happened with those patients that gain a lot of weight or lose a lot of weight. Did they change their regimen? Yes or no? And what happened afterwards? Thank you.
Sure, of course. So do you have a specific study that you're asking about, or just in general?
In general.
Okay. So, well, thank you. Great question. By the way, I'm looking forward to a visit to Slovenia one of these years. I've never been. I think the closest I've been is probably Prague, and Prague is amazing. So I'm looking forward to making it there one of these years.
Well, you will love it.
Thank you. Thank you. I'm sure I will. I have Eastern European roots in my family as well. My father's from Moldova, so I have some feeling, and my mother's from Turkey. So I have certainly some feeling of being an Eastern European in my heart. And to answer your question, so it is fascinating, but the advanced trial, which again was the trial that everybody said, oh my God, look at all this weight gain. Not one of the participants in that trial chose to discontinue their regimen, even though they gained all that weight. And that was one of the more interesting questions for the investigators, because the way they presented it was, oh my God, look at all this weight gain, what a disaster. And then when we asked them, because obviously we donated the FTAF and the F-Truvada, and we said, so what happened to these women? And they said, they haven't actually stopped, that none of them want to stop. And then we dug further, and it turns out, as I mentioned, they were returning to the societal norm. For them, they were actually becoming normal South African women. And we look at it from our culture and say, oh my God. And they looked at it and said, wow, I look like all of my friends. So it's very interesting to learn that, because I didn't know that. And that was some very interesting insight in terms of how do people judge their weight. So they didn't want to stop. The protocol is now coming up. I'm sorry, go ahead.
I'm sorry, but that's really a specific society. It's not something that we see in our culture.
Of course. No, I say that only because that's the advanced trial. In other cultures, actually, certainly that people would look at that and say, I don't want to have that happen to me. And what's interesting is we don't see the same weight change in other cultures, because in the same regimen, when we look at BF-TAF, let's say in Japan, where I'm sure you know, when people in Japanese, their average BMI is 20. They don't gain much weight on BF-TAF. So it really does matter where you study the drug will determine what the weight change is. Not everybody is having the weight curves of advance. In fact, most curves don't look like advance. Advance is unusual. So when we ask clinicians, what we find out is I rarely see that kind of weight gain. I see 1 or 2 or 3 or 4 patients who gained a lot, but most of my patients are okay, or they gain 1 or 2 pounds. And so really the question is, what do I do about the percent of people who gain a lot wherever you live? And the short answer is, again, there are clinicians and researchers who are trying to work out antiviral switch studies. Since Tango didn't show a benefit of stopping TAF, the question is what else to do? Some people are looking at switching off integrase to other classes of drugs to see if stopping integrase does it. Since Tango showed no role of TAF, maybe stopping integrase will have an impact. I don't know the answer to that, but we'll see. So that's one line of investigation that's going on. There are other people that I think are really more focused on what I would consider really the center of the story, which is the hard work, which is what can we do that helps people lose weight through all the usual ways that we help people lose weight, which is change how much you eat, change your calorie intake, and move a little more. It was about 6 months ago that the New England Journal published a randomized article of changing diet, changing exercise, and giving people a coach, giving people, a lifestyle coach, and saying, take this seriously. Don't just, say yes and then go home and eat the same amount. Like, take this seriously, because it's easy to come in here and complain about your pills, and it is harder to change your behavior, but that is proven to work. And changing antivirals might change some people a little bit. I think it's certainly possible that somebody who changes an antiviral might change their weight a little bit, absolutely. Again, Tango's the only study to say that didn't work. What else could we do? I don't know. Again, some clinicians are looking at changing integrase, as I mentioned. I don't think there's too many other switches being considered, partly because that's the only other thing that people are worried about is what happens if you stop the integrase. And we'll see, we have no data yet. If that doesn't work, then we're really left with, when I worked as an internist, there was a physician who was an expert in helping people lose weight. And it's a science, and there are things that people do. And I'm not even talking surgery. There are things that work to help people lose weight. I agree that there clearly are anecdotes of I took my antivirals and I'm gaining weight and I didn't change what I'm eating, I promise. So they may be I'm not saying the antivirals aren't relevant to the story. Suppressing virus in the lymph tissue in the gut might allow us to better absorb nutrients, possibly. I mean, these are effective drugs. Maybe now that the gut lymph node architecture has less virus, even low level viremia, and is better able to absorb, maybe we simply absorb more calories from the same amount of food. Most of the studies so far don't see changes in caloric intake in people who gain weight, which makes no sense, because how else do you gain weight if you don't eat more? And if it isn't eating more, then it must be you're absorbing more or burning less. And we haven't seen any evidence that people are burning less. But burning less is, then you know how to help people burn more. As a colleague of mine, Andrew Carr, said at the recent Glasgow conference, he said, basically the advice should be help your patients to breathe faster, because anything you do that makes you breathe faster means you're burning more calories. Whatever that is, whatever their favorite activity is that causes you to breathe faster, do it. And whatever your favorite thing is. And there are a lot of things that cause you to breathe faster. So do those things. That's easy advice. And consider your caloric intake. And, people, physicians know something about nutrition. We know something about calories, but it's fair to say most of the population don't. And they don't know where the calories are in food. So as we try to figure out this mystery and what else we can do with pills, it's fair to say, even if you're gaining more weight now than you used to and you haven't changed your diet at all, let's at least talk about what your diet is and see if there's high calorie foods that we can modify.
So another short question. Sorry, Gabi.
No, it's okay. I can do it later.
No, just continue.
I just wanted to comment on this weight gain. I do think it's not a big problem. We see that also in our practice, that it's not a lot of people that gain weight, but there are some, maybe in my cohort, maybe 2 people that I cannot say what else could it be, because they got quite a lot of gain of weight. And I'm thinking of what to do. Should I switch? Should I not? And what to switch to. So I think that this data that we have at this moment is maybe not, as you already said, probably there's a genotype of people that have a problem with this, combining with certain antiretrovirals. And this is just a small amount of people, and we need a very big study to see those people probably, I don't know. I think Tango was also not really statistically significant regarding the gait gain, so weight gain. So we will see that in the future, but probably there's just a few people that have problems with this that are really significant. Others are not so important. Thank you.
I agree. And the only other thing to say is Gilead agrees with you. There are outliers. We are in the final steps of a manuscript in which we are looking at all of our switch trials and focusing on the outliers, those who gained at least 10% of weight in all the switch studies, to try to understand, is there anything that we know from anything we collect that predicts who they are and what to do with them? We don't collect genotypes because, as you know, there's a whole rule about getting genome data on people. So that research is unfortunately not going to answer that anytime soon. But we have everything else. And so we are looking at markers, we're looking at whatever we can figure out to understand the outliers, because I agree with you, if we can understand the outliers, we will move to the next step, because every clinician has those one or two in whom they gained a lot of weight, and they are convincing that they didn't change what they're eating. So something happened, and I don't know what it is. I know that it isn't, and again, I know it's a rare event. I agree with that. I don't know. I don't know like anybody else doesn't know. I think we are all learning. But as I say, Gilead is looking into it. As I say, we're in the final stages of a manuscript to share what we know. And we're working with many investigators in the US and elsewhere who are expert on this to try to come up with research ideas. And we're working with people who put people in boxes of calorimetry boxes and measure their metabolism and really investigate this at the basic science level. We actually presented some data from a Spanish investigator who got a grant from Gilead to put these integrase inhibitors with fat cells in vitro to see if there's a change in fat cell metabolism. He didn't see very much, but again, we're willing to explore any mechanistic thing that somebody can do to say anything that's helpful to the field, because we agree it's a mystery.
So short question. 10 years ago, there's a famous statement, Francois Barré-Sinoussi, towards HIV cure. So according to your opinion, how close is Gilead? Okay, how close are we to this approach?
Great question. I don't know. As you know, there are a few people who have been cured by the stem cell transplant world, and that inspires some very, very smart people to try to replicate that with far less dangerous approaches. Gilead has actually one of the largest teams within Gilead is the cure team in terms of funding. There's a lot of effort going on. And the approach is kind of the familiar approach, which is wake up HIV out of its dormancy, right? And then target those cells for destruction, because obviously if you do that enough times, you win. So how do you do that? Well, Gilead has at least one drug that has a name now, vesitolimod, which is, it's always a good sign when a drug gets a name. So it now has a name because it seems to wake up HIV out of dormancy at some of the time, it's not 100%. And we have a couple of ways of targeting those cells for destruction through broadly neutralizing antibodies, as well as vaccination approaches to use your own immune system, and to see if combinations of that will work. We actually have cured 2 monkeys, or actually, yeah, well, we could safely say we've cured 2 monkeys of SIV with this approach. And I say cure pretty deliberately, because not only did the monkey have absolutely no evidence of SIV in the system after doing those things, but when you took lymph nodes from the monkey and put it in an SIV negative monkey, SIV didn't grow. So it looked like that monkey went from having SIV to not having SIV. So there's cause for optimism, and this approach has worked in an animal model, and therefore there may be a path forward. All I can say is HIV is an intimidating virus in terms of how it hides and so on and so on. But it may be in our lifetime. It's certainly possible that in 20 years somebody is going to do the first cure in a person. It's certainly possible. I don't see that as impossible.
Thank you very much. So probably you are also involved in COVID-19. And
Yes,
we know that, okay, vaccination is coming, but we'll have problems for months or years with patients. So urgently we need antivirals. So we have your remdesivir, but we all know it's not very, it's like the beginning of HIV. Maybe it's better than AZT was in the beginning, but it's not something that would be really effective. So it's Gilead working on some antiretrovirals in COVID-19 to take advantage of you.
No, of course. No, happy to talk about it. Yeah, so the short answer is yes, absolutely. As you said, since Gilead was able to find the first effective antiviral, Gilead would love to find the second antiviral. What I can say is we've screened a library of antivirals we already have, including tenofovir, TAF, FTC, et cetera, and none of them work. Interesting enough, of all the currently available antivirals, a few of them had a little bit of a signal. Nelfinavir of all antivirals had a little signal, but not at the doses that were used in people. So it brought a smile to my face to see Nelfinavir show back up for COVID. Nevertheless, and Covisistat actually had some activity against COVID of all things. But in any case, unfortunately, not at doses that we can use. These were at high doses. So. Yes, we are looking, and at the moment, all I know is we are still looking, that we haven't found the second promising antiviral. Not yet. This is obviously a tough one to find antivirals for, since, as you know, no other company is announcing antivirals. There's passive immunity and vaccination, and I don't know why it's so tough to find antivirals for this one. I should actually ask the scientists what's making this so difficult, but obviously it's difficult.
Okay.
It is one of the cool things about working at Gilead is that I can email the guy who found remdesivir 10 years ago and say, Tomas, how come you can't find the second one? What's taking you so long?
Great. Thank you, Dr. Cal, for excellent presentation, and thank you to our audience for great questions. It was a delightful discussion. Dr. Cal, is there anything else you would like to say before we wrap up?
Well, thank all of you for participating, for staying with me for 90 minutes. I hope you can tell I enjoy this. I'm very glad that all of you are still interested and active in our field. Obviously, Zoom makes it amazing that we can talk across continents. I'd still rather be with you at night and having now I'm going out to dinner with you and sharing stories of life, but maybe next year.
Thank you, and thanks to our audience for being here today. We appreciate that. We hope you enjoyed the presentation and that we have managed to answer your questions during the discussion. As I have already said at the beginning, if you have missed on some important points, I will be sending you a recording of this webinar on demand. And thank you once again for joining us. I would just say that there is still a lot of uncertainties going on, but Christmas is coming. So I would like to wish everybody a Merry Christmas with your loved ones and a very happy New Year 2021. So stay safe and take care all.
Bye-bye all.
Bye.